So, good evening, everyone. As you all know, this is the third episode of PAX International Web Symposium. We came up with the idea that we should relive all the best lectures again so that all of us get a chance to learn and reflect back to the topics we had in PAX 2024. So, before we start this session, I'd request Dr. Talwar sir to say some words about this topic and how is he feeling this about this third episode. Sir,
Good
please.
evening, everyone. Thank you, Kanishk. And it's been overwhelming response which we have been getting on this International Web Symposium. And because of the international faculty, the interest has been growing in leaps and bounds in the last two episodes. And this one has come as a very big surprise because when Professor Roland Bull decided that there is so much new which has added in the last couple of months. So I think this is really the hottest season of the hottest topic of the season, where every month something new is coming, and we are very lucky today that Professor Roland Bull will be giving a live lecture in which he has added some slides and a new information which has come in this particular field of biologicals in COPD. So it's going to be a very exciting one. Your host will be Kanish Kumar and your moderator will be Nagarjan Matru, and we'll have the two panelists, and I think it's going to be a really great fun in learning in something which is going to completely change the landscape of COPD management. Over to you, Kanishk.
So, without wasting any time, I request Dr. Nagarjuna Matru to come up and take this session further as a moderator. Welcome, sir.
Thank you so much, dear Kanish, and thank you so much, Dr. Talwar sir, for conceptualizing this idea of International Web Symposia. I'll just talk very briefly about why this is very important, COPD and biologics. So just to put it short, India is called the global capital of COPD because by numbers we beat every other country. It is estimated that at least there are 50 million people living with COPD in our country alone, and this is only an estimate. The true numbers may be even higher. So that is the importance of COPD. Now then, why biologics? So in COPD, just like asthma, we have a vast majority of people who remain uncontrolled despite triple inhalation therapy. So what do we do for those people? How do we improve the quality of life? So I think that is where these newer biologics would help in. For asthma, we have been using biologics for the last decade with extremely good results. And we are very keen, very eager to use biologics in COPD also. So till date, we have not started using them, and we are very hopeful that in the next coming years, we would be flooded with a choice, an array of biologics for us to use and to improve the lives of patients with COPD. But as of today, it's a learning lesson for all of us. And with this very brief introduction about why biologics in COPD is important, it is going to be the future of managing severe COPD. I would take this opportunity to introduce our esteemed speaker. We are very honored to have you here, Professor. So Professor Ronald Bull is here with us. So though he doesn't require an introduction, it is my duty to introduce him to all the people who have logged in here. So he heads the Department of Pulmonary Medicine at the Mainz University Hospital, Germany. All of us have read the articles. Every one of us have read articles. So he's a clinician and a researcher. And he has been a member of both GINA and GOLD. So the two practice changing which we have to read day in and day out. So Dr. Bull is the author for both of them. And if you look at his CV, it is the number of peer-reviewed original articles, 400 plus. The amount of effort it takes to get one article out in a journal is humongous, and having 400 plus is something which is only a dream for most of us. And we have such a learned person, and I think we should make a good hour and learn whatever we can from his talk and the panel discussion which would follow. And more importantly, why this is important, he has been a principal investigator for most of the clinical trials involving the biologics in COPD. So with this very brief introduction, we would request Dr. Bull to give his updated lecture which has come as a surprise for all of us. And then after the lecture, we would have a panel discussion. I would be introducing the panelists to both of you. So with this, I would hand over to Dr. Bull, sir. We are looking forward to learn from you.
Thank you very much for this very kind introduction. And just to be fair, my main affiliation is with the GINA Asthma Committee. But as you said, I'm very much interested also in COPD. And we have been participating in, don't ask me how many clinical trials. I firmly apologize for updating my lecture I gave last year. And again, thank you to all of you, in particular to Deepak, for inviting me to the PAX meeting last summer. It was really a very, very stimulating event. However, ever since, there have been many new data presented at the European Respiratory Society meeting in Vienna last autumn. A clinical trial, a decisive phase 3 trial, I will show the data, has been finished, and as a consequence, the GOLD committee have updated their guidelines for COPD. This is why I decided, and again, sorry for it, this is why I decided it's better not to show my lecture from last year because it's simply no longer up to date. So let me give you an overview of what happened ever since, and I will try to share my screen with you, and please stop me if you cannot see it. First of all, let me briefly start with my potential for conflicts of interest. As you said, for now over 30 years, we do participate in clinical trials. This is why I firmly interact with all the big names in the field, as you see here. When we speak about COPD, as you said, and I fully agree, biologics, as they did in asthma, will clearly change the landscape in COPD within the years to come, and it's not going to take many years. This is very, very safe to predict. As a clear indicator of what's going on, the GOLD committee changed their current recommendations. They added now to reducing risk, a clear recommendation to not only prevent disease progression, but also to prevent and treat exacerbations and to reduce mortality under the overarching umbrella, reducing risk. And biologics do play a major role while this recommendation has been modified. This is the new COPD GOLD algorithm on how to manage patients with COPD who do exacerbate. And I highlighted the main changes in red. If you have a patient exacerbating despite treatment with ALAMA and usually and/or ALAMA, if these patients have more than 300 eosinophils, so yes, exacerbations and more than 300 eosinophils, then there is a new recommendation added, and this is dupilumab if patients also have symptoms similar to chronic bronchitis. And I'll explain this in a moment. So now if patients who cannot be controlled on triple therapy with an inhaled corticosteroid, ALAMA and ALABA, these patients have a third alternative on top of roflumilast and azithromycin. And now let's be very honest. In my opinion, this new option, dupilumab, in exacerbating COPD with eosinophilia is by far superior to what to expect by roflumilast or azithromycin. I won't take too much time, just give me 1 second. This is a clinical trial, a phase 3 trial of roflumilast in COPD, and as you see, you have about 13 to 14% reduction in exacerbation. This is just a minor result. Same, this is the data for azithromycin. There's just one decisive clinical trial, the one you see here. And yes, there is an effect of azithromycin in exacerbating COPD. Even so, at least in Europe, our health authorities clearly recommend to not use long-term azithromycin because, and I don't have to tell you, there's quite an unfavorable balance between benefits and potential side effects, and also compared with what you will see in a minute with biologics, the outcome, the effect, the impact of azithromycin is quite limited. This is the reason why, and this is an analysis I did as a consequence of our meeting last summer. Thanks again for having me. This is an analysis we did of German data from German health insurances. And these data clearly show that only a very small minority of patients with COPD in Germany are actually treated with roflumilast. Why? Simply because roflumilast has a quite high potential for side effects. At least 1/3, if not more, of patients treated with roflumilast complain about very severe gastrointestinal problems, and same is true for azithromycin, also quite a small number of patients. And for the sake of time, I didn't show the data. There's also a very small, very low number of days of when patients are actually treated with azithromycin. So these two are clearly not a good alternative. This is why treatment with a biologic, and the number one biologic is dupilumab, and I'll explain why in a moment. This is why dupilumab made such a big difference. This is the first phase 3 trial, the BOREAS clinical trial. And as you see here, a quite large number of patients with COPD who did exacerbate despite treatment with triple therapy were treated with either dupilumab or placebo for 1 year. And these patients had to be on triple therapy for at least 3 months before the treatment was started. And the outcome was very clear. However, I'd like to make a very important point. As I already said, and this is the basis for the new GOLD recommendation, only patients were included who had a history of high exacerbation risk. They had to have at least 2 moderate or 1 severe exacerbation within the past year, despite being on triple therapy, as I just explained. They had to have signs and symptoms of chronic bronchitis, and importantly, they had to have a blood eosinophil count of at least 300 cells at the screening visit. So we're not talking, and this is important, of the overall COPD population. We are talking about a subset of patients, very nicely characterized, and GOLD has taken over exactly this subset, the definition of this subset. This is now base of the GOLD recommendation. In this population, however, dupilumab was highly effective. We have a 30% reduction in exacerbation. This is by far more than what was seen with roflumilast, and also definitely superior to azithromycin, with a very, very good side effect ratio. There were actually no major side effects as part of this trial. Same, we have it's not impressive, but it's clinically relevant. We have an impact of the biologic treatment also on lung function. Lung function improved, and lung function improvement was maintained over the 1-year study period in both pre and post FEV1. And also we have a very nice effect in the second phase 3 trial. This was a copy of the study design of the BOREAS trial, NOTUS. As you know, in Germany or in Europe and in the United States, you always need 2 phase 3 trials to get the drug registered. This is why the sponsor had to do a second phase 3 trial. This is now the NOTUS trial, and NOTUS showed in the same population, this is important, again, exacerbating patients on triple therapy with lots of eosinophils. In this population, exactly the same effect, again, more than 30% reduction in exacerbation. So in my opinion, this is now a very solid evidence base. And this is true not only on, the effect is true not only on lung function and exacerbations, but also on quality of life. This is the St. George's Respiratory Questionnaire measured in the last week of study, and you do see a similar impact in both NOTUS and BOREAS trial. So you can even expect, it's not overwhelming, but you can expect a real effect also when you look at quality of life. This is why now, based on these 2 phase 3 trials, BOREAS and NOTUS, similar results in both trials. This is why in Europe, the EMA, the European Medicine Agency, late last summer, they approved dupilumab for treatment in COPD. Dupilumab is now an official addition to our treatment armamentarium in COPD. And this is the exact way the EMA recommends to use dupilumab in adults as add-on in uncontrolled COPD, characterized by high eosinophil numbers despite a combination of ICS, LABA, and LAMA, and a combination of LAMA and LABA if ICS for whatever reason is not appropriate. So again, we are not talking about a maintenance treatment for every COPD patient. It's a specific treatment for a subpopulation which is well characterized. And again, GOLD has taken this over. This is now the official recommendation from the 2025, just a couple of weeks ago, from the 2025 GOLD recommendation. Same in patients with moderate to severe disease with a history of exacerbations, chronic bronchitis, and blood eosinophilia. Try dupilumab. It reduces exacerbations, improves lung function, and improves quality of life. So in my opinion, this is now a new game changer in the way we manage COPD. This, of course, and we discussed it before this meeting started, this brings up the question, now dupilumab is approved in COPD. What about the other candidates? What about, I don't think omalizumab will play a role in COPD, but what about MEPO? What about benralizumab? What about tezepelumab? And we now already have quite good data, and I give you my opinion, my prediction, what is going to happen in the next month and years. Let's start with mepolizumab. Mepolizumab was already tried in COPD, and there were 2 phase 3 trials, and one was in a more overarching population, irrespective COPD, irrespective of eosinophils, and then there was a second study in patients with high blood eosinophils. And this trial showed that in the total population, this is on the left-hand side, there was not much effect of mepolizumab. However, if you look at only patients with more than 300 cells, 300 eosinophils at least once before patients were included in the study, then you do see an effect similar to what was seen with dupilumab. This is shown on the right-hand side. And you can have a more closer look. This is a sub-analysis, a post-hoc analysis. This was not pre-specified. You do see that starting with about 300 eosinophils, similar to what was seen with dupilumab, you also see a nice effect of mepolizumab. And this is why you will now not be surprised that yes, also mepolizumab will reduce exacerbation risk in COPD patients with an eosinophilic phenotype. And just a few weeks after our PAX meeting last summer in India, there was a press release from GSK. They have done a second phase 3 trial, the matinee trial, now only focusing on eosinophilic COPD patients. And this matinee trial was positive. It met its primary endpoint and showed a reduction in the annualized rate of moderate and severe exacerbations. And again, I have not seen the full data set, but it is very safe to predict that either at the QAI meeting or the ATS meeting in the next weeks, we will see the full data set, and it is safe to predict that the outcome will be somewhat similar to what was seen with dupilumab. Exactly the same is true for benralizumab. Our center has played a major role in the Galathea trial. This is Terra Nova and Galathea. Again, there was first a look at the overarching at all COPD patients, and here the outcome, as you see here, was completely negative. Biologics do not play a role in the whole COPD population. However, very similar to what I showed you for mepolizumab, if you post-hoc look at patients only with high eosinophils, this is at the bottom of this slide, you do see, yes, something is coming. This is why the sponsor has done a post-hoc analysis published at the ERS Congress showing that yes, also benralizumab, by reducing eosinophil numbers in patients with more than 300 eosinophils, despite, now you know already the story, despite triple therapy and frequent exacerbations, you do see an effect also of benralizumab. So again, There is another phase 3 trial now ongoing, not yet finished, to be finished soon. And it again is safe to predict that we will see an effect similar to what was seen with mepolizumab. And this brings up the final question. This has been published just a few weeks ago. This is tezepelumab. Now we're discussing not a phase 3 trial, but a phase 2 trial, the COURSE trial. And COURSE, again, I'm sorry, now it's boring, again showed that in patients with high eosinophils and in patients with frequent exacerbations, you do see an effect of tezepelumab. So I'm sure we will also soon see a positive phase 3 trial. And this is my last slide. And this is also to bring up another question that is at the moment intensely discussed within my friends. This is not relevant for the clinician. I'll tell you in a second why. But the big question is, what is COPD with type 2 inflammation? There is a group of my colleagues, they say, these patients have clear COPD, but they also have asthma. They have both diseases. And then there's a second group of people who do say, oh, in reality, they have asthma. These are all smoking asthmatics. And then there's a third group saying, we now define a new subtype of COPD, the so-called eosinophilic COPD. And my recommendation is, yes, this is highly interesting, and we should continue this discussion and solve the problem, however, within our ivory tower. For the clinician, the message is very clear. If you have a patient with eosinophilic COPD or with frequent exacerbating COPD and eosinophils, please treat this patient with a biologic to prevent exacerbations and to prolong life by reducing mortality. Later on, we can decide which of these three alternatives is true, but for the time being, please use a biologic in patients with triple therapy, exacerbations, and eosinophilia, the TEE message. This is my conclusion. Please keep this in mind. Thank you very much for your attention.
Thank you. Thank you so much, sir, for the wonderful lecture, which was precise. And whenever I attend all these episodes, I learn a lot, maybe much, much more than what I attended live in PAX 24, because there is always something new to hear and there's something new to learn. Now, I request Talwar sir, your take on this. What do you want to say? You want to say something on this updated knowledge? You're mute. You're on mute, sir. You're mute.
Very excited to see that finally, it is I think what Professor Bull has said is that rather than waiting all these things, you know where the signals are coming from and which way they are taking you. I think it's the right time to take. And he has been mentored to us right from, I think, 2015 and 2016, and instrument behind the severe asthma services which we are having, and obviously teaching us about biologicals. So I think it's like a godfather telling us that what is coming on the way. But let Nagarjun now take over.
Don't flatter me. Thank you.
So I request Dr. Nagarjuna Matru now to take over the session and proceed further, considering the discussion, considering the Indian aspects as well when we talk about the biological. Sir, please.
Yes. Thank you so much, sir. Professor Bulza, it was a wonderful deliberation, as is expected, and to the point, I should say. So without wasting much time, we only have 30 minutes to discuss the practical aspects of something which we look forward to, biologics in COPD. And to join us in the panel discussion, we have two of my dear friends, both of them very learned, very sought out in their respective states. So I would like to introduce Dr. Rajesh Venkat. So welcome, Dr. Rajesh. So he hails from Kochi. He heads the Department of Pulmonary Medicine at one of the premier tertiary care hospitals, the Rajgiri hospitals in Kochi. And I would also like to welcome Dr. Prabhu Prasad. He comes from Goa. He is also very keen interest in airway diseases, and he works in the Manipal Hospitals, Goa. So welcome Dr. Prabhu and Dr. Rajesh to this panel discussion. And of course, we have Professor Bull, who will be overviewing and giving his insights from across the seas. as we steer the discussion to the Indian context. So, as you have heard, the future is definitely exciting. So, Gold has already approved one biologic dupilumab, but the sad part is we don't have it in India. So that is the only sad part. We look forward, not sure when it will be launched in our country. So at this point of time, I should say that we do not have an approved biologic for use in COPD in our country. So I would first like to ask Dr. Rajesh. So if at all we have access to any of the biologics, so from your practice, so what would be the percentage of patients of severe COPD patients you see would benefit from these biologics? So do you think that they would actually play a role in our country? So you're on mute, Dr. Rajesh.
Thanks a lot, Dr. Nagarjun, and thanks to Deepak sir and Professor Bull for enlightening us first of all, and then allowing me to be a part of this very enlightening session. So, I feel yes, if biologicals are approved in India and they're becoming available in our country, I feel a substantial proportion of patients would really benefit from it. In the sense, if I compare it vis-a-vis asthma, asthma is a disease which is easily controllable, and the relative number of patients who would really require biologicals is pretty small proportion. Whereas COPD is a relentlessly progressive, destructive disease. So that way, the proportion of patients which actually would benefit from such treatment would be pretty high. The other caveat is that you have a very high response rate, in the sense the reduction in exacerbation with a biologic in asthma is pretty high, whereas in COPD the reduction is modest. But taking away that particular fact, because of the fact that COPD is such a progressive and destructive disease, I would feel that the proportion of patients who would actually benefit from COPD would benefit from biologics when they become available in India
Yeah.
would be pretty huge.
So wonderful. I think the point very well taken. COPD is a progressive disease, so everybody at some point of time would eventually be a candidate if at all is in that eosinophilic variant of COPD. So Dr. Prabhu, now my next question to you is, because we do not have a biologic as of today in COPD, so if you have a person who is exacerbating despite triple therapy, what would you do more to make his life better, to ease his life?
Thank you, Dr. Nagarjuna, for that question. First of all, I would like to congratulate for the wonderful presentation Professor Bull has given. I think it's a very promising studies and results which he has shared with us. And I think, we're looking at his presentation, I think we are very confident in managing in the coming years about very severe COPD patient populations. So coming to the questions, I think this is one of the most difficult question to answer. I think I would say to begin the discussion and also answer, because as far as my knowledge is concerned, for the last, more than 10 years, I think it took global experts to kind of get approval for eosinophilic the group of COPD patient to get an approval for this kind of dupilumab and other biologics, but that really covers the pathway which is eosinophilic. But I think the research which is not at have a result is a neutrophilic pathway. But the having said that, the key issue in our Indian scenario is, I think, 2 to 3 key issues we should concentrate. That is, one thing is the treatment adherence, and also the compliance of the patients with this particular group of patients. If you take out the eosinophilic group out, and if you focus on this neutrophilic, and also we know that there is no available biologics which are approved for usage in India. So what I would see that maybe we should focus on increasing the adherence and compliance of this group of patients. But the problem with, we have seen with a lot of studies also that more than 50% of our primary care approach in COPD patients, and also with physicians, which non-respiratory physician which deal with these kind of patients, are that inhaler management is not up to the mark to the guidelines of the gold categories.
So, yes, Dr. Prabhu. So I think the point which I think Dr. Prabhu wants to say is that relook at the compliance to the medicines, the
Compliance,
technique,
yes.
go back to the basics, and probably you might
And also,
a
Dr.
subset of
Nagarjuna,
patients. Yes.
yeah, and also I would like to make a point that we say that we are putting on a patients of triple therapies, but really that triple therapy is a multi inhaler triple therapy or single inhaler triple therapy is a huge difference is there, because in we know that SITT, the single inhaler triple therapy, has got a good adherence. With that good adherence, I think the exacerbation rates and the future I think outcome also will differ from not using multi-illness. So basically these kind of points like improving the adherence, compliance, and also public health policies like air pollution, all those things can make a little difference, not going into the pathway of eosinophilic.
Yes. So thank you so much. So now I would like to take the opinion of Professor Bull. So now that, sir, you have shown us the data, and you come from a place where you have access to all these biologics. So in real world, so what percentage of severe COPD patients in your practice would you eventually give dupilumab?
That's a very relevant question, and the number is below, let's say, 10 to 15%. Because again, in Germany, for insurance companies to reimburse the treatment, patients have to fulfill the criteria I mentioned. And as I said, this is a subpopulation of patients, so we're discussing anywhere between 10 and 15% of patients. I want, however, to make an additional point. Rajesh made a very, very important point. He was saying that the effect we see in COPD is only about half of the impact on exacerbation we do see in severe asthma. And he gave the explanation. This is a self-fulfilling prophecy. COPD is a destructive disease and asthma is an inflammatory disease. This is why, of course, we cannot expect the same improvement in lung function and the same reduction in exacerbations. At the same time, however, we have to keep in mind that COPD is also a major trigger of severe cardiovascular events. Patients with severe COPD who do exacerbate, they have a high risk to die not as a consequence of COPD, but from accompanying cardiovascular diseases, myocardial infarction, stroke, pulmonary embolism, and so on. And this is why even by reducing exacerbation risk by 30 to 35%, you still have a major impact on mortality, which is larger than what we see in asthma, simply because the mortality risk in asthma is not so high. So I think the cost-benefit ratio of biologics in COPD is similar to what we see in asthma. It makes sense to treat a patient with a biologic. However, as I said, let's be very honest. This is nothing for the large COPD population. If you have a patient who tells me, I cannot climb one flight of stairs without being completely out of breath, the biologics will not help this patient. They will not make new alveoli regrow. They prevent exacerbations.
Wonderful, sir. I think this brings out a very important aspect that the benefit to a person is beyond decreasing exacerbations, because we all know that the COPD exacerbations are a systemic disease. So there is a spillover of inflammation to beyond the lungs, and there is wealth of data which says that after a COPD exacerbation, the risk of cardiovascular mortality is higher till 1 year after the exacerbation. So
Exactly.
even if you decrease the exacerbation by 30%, you may actually prevent mortality. I think wonderfully put. So a 30% decrease in exacerbation may extrapolate to a larger prevention of mortality. Beautifully put, Professor Bull. So now I have another question to you again. So in asthma, we have a lot of data, a lot of registries data which says that 80% of severe asthma is eosinophilic phenotype. So now what is your take on the COPD? So what percentage of severe COPD are actually eosinophilic COPD?
I think the number of eosinophilic COPD patients is anywhere between 10 and 20%. And the percentage of patients with very eosinophilic COPD who would qualify in Europe for a biologic, as I said, is around 10%, maybe a little bit lower.
So
But
this is
again,
again the point
this
which
is
we have to recognize, that only 10% of all COPDs may actually be eligible for any of these biologics. Correct,
yeah,
sir?
but to be fair, we are focusing on the tip of the iceberg. The very large COPD population, most of them are not so severe that they frequently exacerbate. So with the biologic, as we do in severe asthma, we concentrate on the tip of the iceberg, on these patients who are really have a very severe disease and who have a high need of a very efficient treatment.
Yes. So before we go back to Dr. Rajesh and Dr. Prabhu, I would also ask a very practical question to you. This is more for the Indian audience. Now that we do not have biologics as of now for COPD, so what more can we do? I think Dr. Prabhu has brought out 2 points. One is ensuring compliance. Second is switching from MITT to SATT. Both of them have been shown to decrease exacerbations. So what more can we offer to a person who is exacerbating despite triple therapy?
Okay, first of all, you made already the crucial point. Many patients are not aware of it, but eosinophilic COPD, and this is the target population also of the biologics. Eosinophilic COPD patients, they nicely respond to inhaled corticosteroids. So for these patients, a triple therapy is mandatory. So these patients, and as you said, we have now fixed those inhalers, no problem. Adherence is not an issue. They just need one inhaler, but we should make sure these patients have triple therapy. And as long as you do not have biologics, why not treat roflumilast? Why not use azithromycin? You have, however, to tell the patient, and I know what I'm talking about. You have to tell the patient that with roflumilast they have a high risk of severe gastrointestinal side effects, and with azithromycin there may be hearing loss, there may be problems with the heart arrhythmia and so on. So we have to inform patients about the side effects. And then, and please don't quote me, this is now highly illegal, but before the first biologics were approved in Germany, now and then I renamed a patient with eosinophilic COPD. I renamed it COPD and asthma, and I treated the severe asthma with a biologic. This, of course, works. But again, this is highly illegal, and we have done it in very few exceptions when I simply had nothing else to offer to our patients.
Yes, thank you so much, sir. I think this is where Indians are notorious for. So we try to expand our indications of usage the moment we get a chance. So I think what Dr. Bull has said probably is, if a person is so sick, he is eosinophilic, is exacerbating, we have exhausted the options, it may be worthwhile to tell the patient that we want to try an anti-eosinophilic biologic and probably give the benefit. I think that is what Dr. Bull indirectly wanted to say. And I think for all of us here, I think a couple of quick summary for what we can do before biologic is one, ensuring compliance. If he's on MITT, switch over to SITT. If there is a risk factor for exacerbations like smoking, pollution, try to avoid them. This was all highlighted by Dr. Prabhu. And Dr. Bull has already said, in as of today in India, roflumilast still is there, azithromycin is there, but we have to be aware of the side effects. Any comments from Dr. Rajesh? What is your experience with roflumilast or azithromycin in this exacerbating COPD?
Thanks, Nagarjun. So before I answer that, a couple of other things probably which we need to look at to complete the pattern would be to look at whether the COPD patient has an associated substantial bronchiectasis. So an HRCT might be worthwhile. And if there is a bronchiectasis, then treat the bronchiectasis also. Then for the chronic bronchitis phenotype and someone who is a chronic mucus producer, probably some mucus clearance techniques, including the N-acetylcysteine, iodostine, or even OPAP devices might be a choice. Look at the nutrition, rehab, all those things. Look for airway colonization, and then probably treat it. These are some of the additional things that comes to my mind. And regarding roflumilast, I am sure sir would have some difference of opinion. But when it comes to South India, most of them don't tolerate them that well. In the sense, especially the 0.5 dose. 0.25, most of them do tolerate, but most of them do stop the drug when it comes to 0.5 dose, and most of them have substantial side effects, including GI side effects and loose stools and weight loss and all those things. But I think in those who tolerate it does bring down some of those exacerbations. This is my personal take on that. It's not a evidence as such.
And
Yes,
also one more point.
yes, Dr. Prabhu. Yes,
Yes,
please.
given a chance, and if nothing is working, I think we should not hesitate putting steroids also, because finally the control, disease control is the main thing which we have to look in, exacerbations, and then think about future adverse effects.
Yes.
That's what I.
Very
Steroids
important point.
are always the last resort to go. Though our aim is to decrease the use of oral corticosteroids to the best possible. I think if there is no other option, a short burst can always be given. I'll again go back to Dr. Bull. So I'm very happy that Dr. Rajesh brought out this topic of mucolytics in bronchitis variant. In fact, that is the same subset where biologics are also recommended. Correct, the bronchitis phenotype. So, what is your take on the role of N-acetylcysteine and erythrocysteine? Because Indians, I don't know how it is in Germany, but for Indians, sputum is a very disabling, troubling symptom, both physically and for the social stigma associated with spitting. So what is your take on erythrocysteine and N-acetylcysteine for COPD, bronchitis, and exacerbations?
But that's a clinically highly relevant point. Thank you to Rajesh for bringing this up. In Europe, N-acetylcysteine in COPD plays a second line role. However, I fully agree with my colleague. If we have a patient with an increased sputum production and frequent coughing, in particular, a lot of mucus, then we always do a CT scan, as he said, to even realize even minor bronchiectasis, and if so, then we always send them to a physiotherapist to teach the patient how to best cough up the sputum, and in this case, of course, mucolytic, such as N-acetylcysteine and the likes. Then, yes, we recommend treatment. And to put on, to further on, this is a very, very affordable, low price drug. So my threshold to recommend a trial for 3 to 6 weeks with N-acetylcysteine is very low.
Yes, so quickly we will move on because we are running short of time. There's one very interesting question from the audience is about SITT versus biologics. I think the question which they wanted to ask was, when biologics were used in all those trials of COPD, were they actually MITT or SITT? Because SITT is better than MITT. So the additive yield over triple therapy, was it over MITT or SITT? Professor Bull.
I think in a clinical trial, the difference is not so relevant, simply because when you participate in a clinical trial, you call your patient all the time. Did you take your medication? Do you need a new inhaler? So adherence and all these questions, they are not so relevant in controlled clinical trials. But in daily real life, of course, I always recommend, if I have a patient on triple, I always, if at all possible, give it in one inhaler. We all know with increasing numbers of inhalers, adherence goes down. And the potential for mistakes goes up.
Okay, so now coming back to Dr. Rajesh, and this question I would want to ask Dr. Rajesh in particular, is the challenges to using a biologic in a person with COPD. And the reason why I chose Dr. Rajesh is that he has put out a beautiful paper from Kerala on the challenges in accepting a biologic in asthmatic patients. So if you can just briefly talk about your published experience and what you would foresee in COPD, it would be great for us.
Yes, thanks again, Dr. Nagajan, for bringing out that particular point. Yes, we did look at that the so-called artwork study on omalizumab in asthma, where we found out that there was a potential for overuse as well as underuse of biologics in asthma. Overuse in the sense, if you are not going to a proper algorithmic approach to asthma, many of those so-called severe asthmatics may not be severe at all. So if you start using biologics in each and every of those patients, then you may be over-treating. Whereas those patients who really would benefit from biologics in that Kerala setting, in that particular paper, only around one third took biologics, two thirds didn't take biologics. So there were multiple reasons for that, to the extent that there was a discrepancy between the physician assessed asthma control versus the patient perceived asthma control. Even though the patient was uncontrolled, many of those patients thought that they are reasonably controlled, so they didn't take. And of course, cost and the fact that it was a parenteral therapy, the fact that endpoint was not clear, these were some of the practical challenges that came up in that particular study. Now, coming to the second part of your question regarding the challenges that you foresee in COPD patients when it comes to biologic use, then again, as Professor Bull said, the proportion of severe COPD patients who fulfill the criteria, the inclusion criteria of these trials would be maybe 10 to 20% or something of that sort. But still, considering the population of COPD patients in India, this small percentages also would translate to very huge numbers. That is one thing. And secondly, in most scenarios, we look at eosinophil counts during an acute exacerbation. So in acute exacerbation, there may be a bacterial component to it. So we might actually underplay the absolute eosinophil count when we look at during exacerbations. And most of us don't actually look at eosinophil counts when the patient is at their baseline. So after a discharge, maybe after one or two hospital visits, we don't really look at. And then of course cost, frequent dosings. Now when it comes to dupilumab, it's once in 2 weeks dosage, vis-a-vis benralizumab in asthma, where you can, in the continuation phase, you can use it once in 2 months. And then again, therapy-induced remission is less likely in COPD, whereas in asthma, we have some data that spontaneous or therapy-induced remission of disease, at least clinical disease, is common. That may not happen in COPD. And of course, the magnitude of effectiveness is much less than what we see in asthma. But nevertheless, taking all these challenges to us, I still feel we may have good biologics which might hit the road and which might do good job in COPD patients in India.
Thank you so much, Dr. Rajesh. I think one point which I want to stress upon is that not everybody whom we want to give biologic would end up taking a biologic. I think in asthma also, as he has rightly said, one third of people who are eligible will eventually end up taking biologic. So Professor Bull, so in this is the Indian experience. So we would want to learn from the Western world also. So what are the barriers to prescribing a biologic in patients of either asthma or COPD?
The main barrier, even though this is fully reimbursed, the main barrier is still cost, because doctors fear that the average amount they spend per patient, this is one major scale, how the doctors are evaluated. If they prescribe lots of biologics, their average prescription cost per prescription numbers go up. This is why some doctors are still reluctant. But for patients, cost is not an issue. The main problem we have with biologics is for many patients, the expectation is too high. Patients think this drug is so expensive, it must be a miracle cure. I no longer have any problems. I'm completely free of everything. And this is why some patients are unhappy with the result. This is why I always recommend give your patient a realistic perspective of what to expect from the biologic. Your severe attacks will go down by at least 60 to 80%. Your lung function will improve. Your wife will no longer say, I hear you breathing during the night, and you will have a normal daily life. However, you will still have asthma, and there may be an occasion once or twice a week when you realize I'm still asthmatic. This is important.
Thank you so much, sir. I think the point which is very important is we have to be realistic. So we should never say that you'll be 100% better. I think anything 50% reduction in asthma is good, but I think in COPD, I would say even 25% decrease is okay. I think if at all the biologics come in COPD, I think that is being more realistic to the patient when we try to give the biologic. Point very well taken, sir. Now, two last questions from my side to complete the discussion, to make it more complete. So, Dr. Prabhu, coming back to you. So, overall, the goal says that if a person is uncontrolled despite triple therapy and rehab, you have two options to go to. One is the biologic, second is the interventions. So you have a lot of work happening on the intervention front. The lung volume reduction surgeries are there. You're having targeted lung denervations. A lot of work being done on that front also. Now, how in India we don't have all of them. We only have one LVRS, that is the vapor. So, Dr. Prabhu, so once you have biologics, so how would you position these interventions versus biologics?
I think very good question,
I know it's a
Dr.
very
Nagarjuna.
futuristic question, but then
Yes. So I think what I see is the evidence and the safety in this aspect of intervention and biologics, because if you see the data and evidence, I think very good evidence is available for only. Please correct me if I'm wrong, because I think you are very active in doing vapors for this particular this thing, and valves have got a good evidence, I guess. And the problem with the valves is, as you know, that collateral ventilation. So a good lot of patients of COPD will have a collateral ventilation, and obviously there the vapor BTVE comes, but problem with the BTVA I see is safety, I think, because a lot of patients of post vapor, they go into COPD exacerbations and infections, pneumothorax, all those complications. I think that may not be like par with the biologics thing. I feel still the biologics has got a if the cost factor is taken out, I think biologics might be a superior intervention compared to these kind of
I think
intervention.
we're all tilted towards biologics, the COPD. So, Professor Bull, what is your take on these newer interventions? So, people are talking about spray cryotherapy, they're talking about targeted lung denervation, we're talking about rheoplasty, we're talking about valves, vapor. So, how would you position all of these together in the algorithm?
I think it's a very exciting development, and I very closely follow this new development. But in all these interventions, it's even more important compared with biologics to select the right patient for the right intervention. And you managed a few examples. For instance, collateral ventilation. Emphysema only in several parts of the lungs. There are so many things you have to observe that in the end, the number of patients who qualify for an intervention is very low, and the long-term effects of these interventions compared with my experience with COPD long-term is not very good. But with asthma, I have done the first biologic omalizumab in 1997. So I can tell you, biologics in asthma, the long-term effect is remarkable and absolutely spectacular. And I have not seen similar data with all these interventions in COPD, more so if patients continue to smoke.
Yes, thank you so much.
Can I just add one thing to that here?
I think
In India, if someone comes to Dr. Nagarjuna, he will get a BTVA. If he comes to
no,
Rakesh,
I'll completely disagree. So what I wanted to say was exactly the same thing. A very small subset of people actually benefit for interventions. In fact, the groups are different. So lung volume reduction is for emphysema. Biologic is for bronchitis. I think they cater two different groups of people. That is what I wanted to say, that they're both catering a different subset of people. Now I will I again ask Professor Bull very very thought provoking question. See, in India the data says that more than 50% of our COPD is non-smoking COPD. So most of the trials of biologics in COPD are smoking COPD. So what is your prediction if we extrapolate the results of smoking COPD trials to non-smoking COPD?
Please, what I'm saying now, take with a note of caution, because my COPD, 99.9% of my COPD patients are smoking COPD patients. There are a few alpha-1 antitrypsin deficiencies and so, but we do not see many non-smoking COPD patients. Even so, you made a very, very important point. Thank you. Phenotyping is the key. You have, as I said, you have to look at the patient to identify the right patient for the right intervention. This may be biologic for patient A, this may be a valve or a surgical procedure for patient B, and in patient C, there is probably at the moment no alternative, and we have to have a much more closer look at non-smoking COPD patients to find out which of these interventions also are beneficial for this other group of very, very exciting and interesting group, but I cannot study it. I cannot contribute my experience because I don't see these patients.
One last question before I hand over to Dr. Kanishk. Again, this is something which only Dr. Bull can probably answer. Is all the biologics which you have spoken about cater the eosinophilic phenotype of COPD? But we are all aware that there's a lot of work happening on the non-eosinophilic COPD also. A lot of trials, biologics targeting IL-33. So, in fact, in India also, we are a part of two trials, the Arnasa and the Hercules, where astegolimab and itepekimab are being tried. So, a few lines on what could be the future for this anti-IL-33 biologics in COPD.
Okay, number one question. I think all the biologics which target eosinophils will have a higher or not so high impact on eosinophilic COPD. Let's wait for the IL-33 or anti-ST2 antibodies in COPD. We only have seen phase 2 data, and I learned in 30 years of history in doing clinical trials, never trust phase 2 before you have seen phase 3. The same hype was seen with anti-eosinophil drugs. All the companies were saying this will be a game changer in COPD for all COPD patients. This didn't happen. We have it for a subpopulation. So wait and see. I will not try to predict, but I can renew what you said. Phenotype your patient. This is the key to success in the future.
Yeah. Thank you so much, Professor. I think that was definitely a comment with a lot of wisdom that you should wait for the final results to be out. I think it was a very great panel discussion with insights from Dr. Rajesh, Dr. Prabhu, of course, Dr. Bull, to give his expert opinion. And with this, I would like to hand over to Dr. Kanishk to take the further discussion forward.
Thank you, Dr. Nagarjuna. It was a wonderful discussion, I must say. But I'm going to request Dr. Talwar sir to make this session, this symposium for 1.5 hours at least, because I'm getting a lot of questions from the audience, and after the session is over, people ask me, you didn't ask my questions, sir. So I'll try to go through it quickly. And the first question is for you only, because as Dr. Bull said, that only 10% of his patients fall into the category of giving a biological, maybe dupilumab, to such patients. In your experience, you are seeing a lot of patients at our center, and we are giving a lot of biologicals in asthma as well. So what percentage of patients, some doctor wants to ask, what percentage of patients will fit into the biological category in COPD in your practice, because you're seeing a lot of patients? You're on mute, sir. Mute. You're on mute.
I wanted to make this comment. I think one is that, Kanishk, you can carry on because you must address the questions. But I wanted to make one point, Nagarjun, that you brought in, Indian non-smoking COPD. But the major thing in the data which is coming from India about non-smoking COPD is it's more eosinophilic COPD. It is not eosinophilic.
I was about to say, sir. In fact, asthma behaving
all the
like
data
COPD is a
shows that
subset of.
eosinophils and inhaled corticosteroids is the two main things in non-smoking COPD, which is a biomass fuel exposure COPD in India. And if that is true, then obviously that 10% will translate it to much more, because we see a lot of suffering in this group of patients because they keep on getting treated for almost everything, but they don't get relief much but oral steroids. So I think we have perhaps a totally a different line which will come up for us because of this non-smoking eosinophilic COPD, which is almost about 50% in our country. So which is like a huge number to look at it. And somebody has asked that what percentage of patients will fit into biological therapy. Well, I can say that, whenever I look at the eosinophils, I look for the weapon which I have to kill the eosinophils, because I think we have learnt this, that eosinophils in patients will play the villain's role, and it's not a defensive role which they are giving, provided you are able to identify that, how the eosinophils are orchestrating the exacerbations in the individual patients. So actually if you look at it, that almost about 50% of our patients in the asthma clinic are actually eligible for biologicals. In COPD, with whatever little knowledge which we have got and whatever the spotlighting is coming, it tells us that almost about 20% of patients will be eligible for biologicals, which is like a huge number because COPD is much, much huge in comparison to asthma.
Okay, so thank you. My next question to Dr. Roland Bull, sir, that he mentioned in his lecture about treating that patient with some biological, that COPD patient, that was illegal from his side. So people want to know that which biological was used by you in that patient. And apart from the clinical trials, the results of the clinical trials, which you showed, what is your personal experience regarding these biologicals in your particular patients?
The answer is on one hand side very simple. On the other hand side, it's not very precise. The more eosinophils a patient has, the higher is my likelihood that I will use either mepolizumab or benralizumab. If a patient also has this cannot be used in active smokers, but it can be used in a COPD in a patient who stopped smoking. The higher your FeNO is, the more likely I'm going to use dupilumab because high FeNO, high nitric oxide levels in exhaled breath tell me there's a very strong IL-13 signal, and then of course dupilumab is by far the most relevant biologic. And if you don't want to switch on your brain, if you say I want a very broad biologic, you can consider tezepelumab, even though, to be fair, tezepelumab is the youngest biologic, so my clinical experience with tezepelumab is only for the last 3 to 4 years. And I hate to say it, but if you have a smoking patient with COPD, I would not use omalizumab simply because it is extremely effective in allergic diseases or diarrhea and so on, but I would not try it in COPD.
Okay, so now moving on to our panelist. I'll ask Dr. Prabhu to answer one of the questions from the audience. So why are the theophylline being avoided in spite of everyone writing it in Indian scenario? So what's your take on that?
I think the literature which says that cardiac safety is one issue, and also monitoring therapeutic index, which is not possible with the theophylline, and also newer generation of add-on therapies have come. So maybe that could be the reason. I think we have for so many years we have been avoiding using theophylline compared to the earlier years. It was being extensively used.
Okay, now we move on to Dr. Rajesh. So the question for you from the audience is, what is the role of yoga and pranayama in COPD or asthma patients, and how do we, use it in Indian scenario? Are we using it? How to promote it? What's your take on that?
It's something which I am not really practicing, and I think the body of evidence is not that robust, although you have evidences. But I feel you can try it, but I may not be the best person to try it on answer. That's the best way that I can tell you.
Dr. Nagarjuna, you want to add something on the non-pharmacological management of COPD or asthma, you mean to say?
So non-pharmacological management is well proven. I think everything other than yoga and pranayama is there in the gold guidelines. But if you talk about the Indian context, no, I don't know for COPD, but at least for asthma, at least there is published data also that yoga, though it is not a randomized controlled trial, that yoga can to some extent alleviate symptoms in some people, either by stress relaxation, may not be the direct disease control, but I don't think that I can vouch for it. But at the same time, if somebody wants to practice yoga, there's nothing wrong. He can practice yoga, and that may, if at all, help him, it may not harm him.
So my next question to Dr. Professor Roland Bulsa. One of the doctors asks that very genuinely 200 pages of gold, and we have around 200 pages of GINA as well. Obstructive airway disease treatment revolve around eosinophils. So can we treat as one disease like obstructive airway disease, favoring the Dutch hypothesis?
I'm not a friend. I know your relationship to England is a little bit difficult, but still, I prefer the English hypothesis. I do think asthma and COPD are two different diseases. However, they may occur in the same patient, and there may be similarities around the pathogenesis. And one of these similarities clearly is the role of eosinophils. So we do need drugs targeting eosinophils in both diseases. And yes, this is why in my last slide, I clearly said, as a practice, I'm also a practicing doctor. And as a practicing doctor, I stay out of this discussion. This should be held in the ivory tower. This is among experts. We can spend weekends and weeks to discuss it. Asthma, COPD, both, or is it a common disease? Whatever. But in daily reality, you have to treat your patient. And if this patient is eosinophilic, biologics, if available, I know in many parts of the world they're not available, but if available, biologics are an excellent choice.
So we are running out of time. I would like to ask Professor Bull one last question. Idea of a perfect biological therapy. What features would it have if you have to make a perfect biological for COPD?
The perfect biological for COPD will target eosinophils and will make eosinophils go away as fast as possible, and ideally no side effects. And also we now have self-injection, so patients no longer have to come see me with dupilumab every 2 weeks. Don't ask me how often I heard, hey prof, I really like you, but seeing you every 2 weeks is just too much. So a longer duration of injection period, this would make an ideal biologic. But ever since we have the self-injection, this is all no longer an issue. If the biologic is effective, if it's available and affordable for the patient, we have the perfect drug.
So we come to the end of the session, but before we always end, we always ask the panelists and the moderator and the experts about the one line they want to give the take-home message to our viewers, that what is the take-home message from your side that they have to inculcate in themselves while practicing. I start with Dr. Prabhu Prasad.
Thank you. So I think the future is very promising for us to treat airway diseases, and the cost factor, if it is taken out, and if we can manage that aspect, I think we are going to be very happy in treating most of these patients. I think future is very great for that.
Dr. Rajesh.
A personalized treatment for COPD patients, look at the treatable traits and broadly adhere to guidelines as well as evidences.
Dr. Nagarjuna.
Dr. Rajesh told my one-liner. Is my statement. I think phenotyping is the crux, but I will change my statement that do not forget the basics. So do not jump to biologics without giving your inhalers correctly. I think that is what I would say.
Professor Roland Bulsa, what's your one-liner message to all of us?
One line, differentiate between difficult to treat and true severe asthma and COPD. Phenotype your patients, and please, you are the leading nation in the world doing new pharmacological developments. Produce many biosimilars for asthma and COPD. This is your job.
Now I move on to Dr. Talwar sir to conclude this session, give insights about what's coming next, and before that, one line message from your side, because of your experience, it's huge, and whatever you will say will be impacting a lot of physicians in India. Sir, please. You are on mute, sir. You are on mute.
I don't know how this message will go across, as Rajesh said to Nagarjun, that it depends where the patient lands up. Coming to the interventions, I see that biologicals have completely eliminated the need of so-called as bronchial thermoplasty, actually, that they had to wind up and leave the whole thing completely, right? As far as the COPD interventions are concerned, I think the emphysema is the part which was not being yet able to get targeted, but rest of them will be very nicely taken care of by biologicals in future. And I think they will be all packing up and then going away. But I have again one very important aspect which I was going to ask Roland Bull was that, mucus and benralizumab has got a lot of data coming up. And in COPD patients, there are ones which have got a lot of mucus issues. So has anybody looked into benralizumab's role, particularly in COPD, which has got mucus related issues? And with that, I think my last one take home message is that in 10 years down the line, we will be treating them with so many biologics in COPD as we are doing today for asthma. I remember in 2015 when we met Roland, that we had only omalizumab, and he said, why, you will get sooner or later. We got two more in the next 2 years, and our life changed after that. I'm sure the COPDs will say the same in the next 10 years.
I fully agree and have nothing to add. This was a perfect final statement.
Thank you so much, everyone, for being with us. So we'll be conducting the next PAX International Web Symposium next month on 29. That will be the last Saturday of every month. And I think the topic is cough, its management, which will be taken by Professor Surinder Breeding. So thank you so much, everyone, for coming and giving your time. Thank you.
Thanks a lot, Deepak sir and Dr.
Bye
Kanishka.
bye.
Thank you so
Enjoy the
much,
weekend.
Professor. Bye-bye.